As we know, prostate cancer is really common. As I said in the presentation, it's 299,000 new cases estimated for 2024. But when we talk about high risk, I think there are multiple definitions, and that's what makes it difficult. I think the easiest ones that we think about commonly are you more likely to die from prostate cancer, and are you more likely to be diagnosed? But high risk could also be, once diagnosed, are you more likely to progress to metastatic cancer? And do you get it at younger ages? I think all of those are key components of the definition. And there's no doubt that the natural history within a population, let's say if you are among a group of people that cluster that have cancer at a younger age, more likely to die from it, that those things aren't impacted by what type of screening you put into place. At the end of the day, we're trying to have a balance between the benefit of screening, which is, that's as a strategy, what we do when we say we want to do screening is we want to look at a lot of people who probably aren't going to be affected by something to find the few that will be, so that we can give them something that they'll benefit from. Now, inherent to that definition means we put a lot of people through a process that may have some harm. And that really is what the crux of the discussion around PSA testing for prostate cancer is, right? Is that to find those few cancers that we need to identify and treat, are we going to be introducing harm to people by having them have a false positive test, or having them have a procedure they don't need, or treatment that they really shouldn't have? So, when we look at a high-risk population, there's no doubt that starting earlier is beneficial, right? So most recommendations are to start at 55. I would say that we have really good data that starting at 45 or 40 is a better strategy. And then I think as people get older and as we get closer to the 70s, having really thoughtful discussions and considerations about whether or not someone would benefit from continued screening. So if someone is 71, they've got a lot of health issues, is it really beneficial to find a cancer 10 years early? But the converse to that is if someone's really in great shape, everyone in the family lives to 100, well, I think, that should be individualized on that, for that person to think about a different screening strategy that might prolong it beyond the ages of 70. But we have to recognize that as people get older, the benefit of screening goes down. I think in the following plenary, you had a presentation by Randy Vince that really beautifully highlighted one of the challenges, right? We have multiple opinions, we have multiple guidelines, statements around what is the right solution for screening. I think equitable and pragmatic screening has to focus on harms because, that is the most balanced way to think about this problem. And what we don't want to do is take a population that we say, oh, you're at high risk, and we're going to do everything for you, right? Because in that process, we're going to harm a lot of people that don't need further testing or treatments. And so to me, we need consensus, right? We need all of the players that are involved in this early detection of prostate cancer to come to the table, have honest discussion about the evidence, and to come up with a solution that is balanced and helps those that want to be helped by finding their cancers earlier. I think the guideline statements that have come out from the American Urologic Association, the Prostate Cancer Foundation last week, highlight appropriately that there are high-risk populations and give really great guidance on how to screen in those groups. But we have other organizations that really matter, like the U.S. Preventative Service Task Force, that don't have such a recommendation. And ultimately, the people that are doing the screening in the communities are primary care physicians, and they rely heavily on that U.S. Preventative Service Task Force recommendation as their guiding set of principles for how to do early detection. The U.S. Preventative Service Task Force and other cancers utilizes microsimulation modeling, like I presented during the talk, to help inform guidelines in the absence of level 1 data. So if you look at the breast cancer and the colon cancer and the lung cancer recommendations, they recognize that there are populations that weren't well represented in the trials, that we can use simulation data, right? Because it's such a rigorous methodology to come up with some evidence to support practice and guidelines. So in the case of prostate cancer, I think we just need to pay attention to the great work that's been done by Roman Gulati, Ruth Etzioni, and the rest of the CISNET team, because within that body of work is some clarity on what should work. And then you asked about what do we need to do next? Well, I think it's a hard pill to swallow, right? Because these efforts are so hard. It is hard to do a randomized controlled trial of 100,000+ people on screening. And screening trials have been difficult across the board in cancer, not just a prostate cancer issue. But I think, we should invest in another trial and try to answer as many of the important questions as we can answer in that trial, and just recognize that that's a financial investment that's going to mature over 15 to 20 years. And that's many people say, why do a trial that I won't even see maybe the end results? Well, because, if we don't do it, then we're going to continue to have these high-risk populations, particularly Black Americans, where we don't have evidence to support sound fundamental screening practices, and we continue to propagate the same things we've seen over the last 50 years.